The data is that close to 76% of those that are unhoused have any mental health disorder. Collaboration. You cannot do this work alone. Try to be a bridge from the streets to the clinic, not the other way around. I have people that have offered Brixadi and they tell me, no, I want Sublocade because so-and-so is on Sublocade and they say it works for them. We are now in a moment where there has been a lot of policy change for unhoused people.
Hello, everyone, and welcome to the Transformed Minds. This is the podcast where we explore the intersection between mental health, addiction, and transformative care. I'm your host, Dr. Owusu, and today we have an exceptional guest who I am so excited to have. In each episode, we take a very thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care from the clinical settings that we work to the community. If you're new here, this is the vibe. We have the Expert RX, where we have guests who are experts in the field. They have studied, they have experiences, and they come teach us. We have the Host RX, where it's just me and you breaking down literature and different things I have learned throughout the years. And then we have the Lift RX, which are people and guests who come here. They have lived it, they have the experience, and they have learned how to help others. And they come here to teach us and help transformed minds. So today we have an Expert RX episode. We're going to be tackling a critical issue of the crossroads between addiction and homelessness. We have Dr. Arbelo, who is here to discuss with us a national study of homelessness, social determinants of health, and treatment engagement among outpatient medication for opioid use disorder seeking individuals in the U.S. Today, we will focus more on the homelessness and how addiction interact. So, before I hand over to Dr. Arbelo, I would love to introduce her. Dr. Arbelo is an addiction psychiatrist attendant at the Connecticut Mental Health Center in New Haven and an assistant professor of psychiatry at Yale School of Medicine. One of her roles as CMHC includes working with the street psychiatry team, which is a model of mental health and addiction care delivery that takes physicians and providers to the streets to meet patients where they're at, to provide care primarily to the people who are experiencing unsheltered homelessness. Dr. Arbelo Cruz teaches psychiatric providers, general physicians, and community workers locally and at Yale and at many venues and conferences nationally. So we are one of those venues that she is going to be teaching today. Dr. Arbelo brings both clinical insight and systemic thinking to this complex problem that we would be talking about today. So before Dr. Arbelo takes over, I would like to share one insightful statistic that I learned from the study. Over 180,000 individuals that went in for an outpatient treatment episode, about 8.7 of these individuals actually were homeless. And that homelessness status significantly affected their retention of treatment and also the completion of treatment beyond 180 days. So if you think about it, most people after 6 months or so, they fall out, they drop out of the treatment. And this is a big issue because we want people to stay in treatment. We want them to maintain stability. We want them to do better and function at their best capacities. And they're not able to do that. So today, let's welcome the amazing, most intelligent Dr. Arbelo here with us to discuss this. Welcome.
Thank you, Dr. Owusu. It's a pleasure being here. Thank you for making this space available to spread the good knowledge at many venues. I appreciate you for that.
We're so happy to have you, and thank you for coming. Dr. Arbelo, before you go into that, can you tell us a little bit more about yourself, if I missed anything, and like the things that you are currently doing, and then we can get into all of that.
So as you well said, I'm Dr. Fabiola Arbelo Cruz. I am originally from Puerto Rico. And I moved to mainland US in 2017 to do psychiatry residency at Boston Medical Center. After that, I did a subspecialty training within psychiatry in addiction psychiatry, where for 1 year I got extra training at treating substance use disorders and psychiatric illnesses, and many times having psychotherapeutic skills to be able to treat skillfully both. I stay in the area at Yale because I did my fellowship at Yale, and I have been working at the Connecticut Mental Health Center for a little bit more than 3 years. And as you mentioned, one of my clinical hats is with the street psychiatry team, which is a model of care that takes a provider and a clinician, like a social worker, to the street to provide mental health and substance use care to people that are on house or with housing instability. But to be honest, Dr. Owusu, I want to pinpoint that our specific population, the target population that we look for, is those that are underutilizers, because there are many people that are on house. We want to capture those that have severe mental illness and many times substance use disorder, and those that have a complexity, severity of illness that they do not go to the clinic, they do not go to the emergency department, they do not go to the hospital. So we want to try to target that smaller population within the homeless community and start engaging with them with the goal of engaging them in care, because many times, one, they might not have the insight of knowing that they have a mental health illness or substance use disorder, or second, they fear or they avoid clinics because of prior experiences. So we try to be a bridge and trying to make it even more explicit, because many times people refer people to us just because of them being unhoused. A motto that we had that I learned from one of our clinicians is we try to be a bridge from the streets to the clinic, not the other way around. If people are in the clinic, we want them to continue being there. Our specific population are those who are not touching healthcare points. So that's one of my clinical hat. My second clinical hat is one of the outpatient teams at CMHC, the Connecticut Mental Health Center. It's a state facility. And the population that we serve are those with severe mental health, many of them with refractory symptoms despite taking medications. And I work with one of the outpatient teams. Two other hats that I have that are important to mention here is that I'm the director of the Social Justice and Health Equity curriculum of the Yale Psychiatry residency. And it's a curriculum that spans all PGY 1, 2, 3, 4 levels. And we provide didactics focused on 4 areas that we think are crucial for social justice in psychiatry. We provide didactics in the area of structural competency, history of psychiatry, advocacy, and the human experience. So I direct that. And fourthly, and importantly, I have a lot of proudness to say that I am one of the mentors in the REACH program. It's a program that focuses on providing cultural informed care and treatment and teach people mainly from underrepresented backgrounds to provide better care to minoritized group with addictions. And I was a scholar in the REACH program, and now I'm a mentor. I'm part of that. And in that hat, I get to do one-to-one mentorship actually right now to a psychiatry resident in the University of Puerto Rico, where I'm originally from. So that brings a lot of joy, a lot of
Yeah.
joy. And we mainly talk about his projects and how to be even better providing addiction care.
Oh my God, that is so amazing. You do so much for the communities that we care about, the communities that I care about. I am very much so drawn and passionate about marginalized communities, making sure that people are providing culturally and spiritually informed care, because
Mhm.
all of these things bring a lot, they make a lot of difference. And one thing that you mentioned about the curriculum that you teach, teaching the history of psychiatry, is very important
Mhm.
for people to know where we came from, where we are now, and where we could be heading towards. But also teaching that human experience, I think, is very important for all of us. So thank you so much for the work you're doing, the populations that you're focusing on, making sure everyone is touching those access points. And I know you started off teaching us what, and actually the definitions, which are important. So I would hand right over back to you.
Thank you. Thank you. So, I wanted to start off by repeating that being unhoused does not have one face. Homelessness is a very heterogeneous experience. There are people that have housing instability, which can look like they're facing eviction. They have inadequate housing, meaning like extreme overcrowding, or the house doesn't have a bathroom or doesn't have a working kitchen. And on the other side of the spectrum, you have people that are unhoused. Those that are unhoused, that don't have a roof under their head, I categorize them like in two groups. Those that are shelter, they can be staying in a warming center or a shelter, which can be congregate or not congregate. And those that are unsheltered, those that literally stay in the streets. Could be in a park, could be in an encampment. They can change positions every night. And that's important to mention because we know and literature says that those people that are unsheltered have higher risk for substance use harms and mental health harms, like worse outcome.
Yeah.
And to add variables of Wusu, those that are unhoused and unsheltered, people have different durations of being on shelters. Some of them have different frequency of episode. It can be that someone had like 5 episodes of being homeless on shelters. It can be that one person have only one episode of 8 months or perhaps 2 months. So it's important to know that there are different experiences of what is to be homeless, being unhoused.
Yeah, that's very important. And through this, I am also learning because I have, for so long, even when you look at the literature, words are used interchangeably, like homelessness, unsheltered, and we all use it. But I love how you've been able to break it down. And the sheltered can be congregate visits or congregate. And we never think about all of these and how they can impact people. And then it comes back down to the challenges, like you mentioned, the episodes, the intensity, the frequency of all of that. Like, how do these different layers and variants of homelessness bring, like, the challenges? How does it differ for these people based on their experiences? What have you
Mhm.
witnessed?
I will give you one clear example from the previous weeks. I have one person, let's call him Brian. He is on shelter, has been on shelter for more years. He's on methadone, which is an FDA approved medication for opioid disorder. And in the United States, you get methadone in specialized clinics. Because he's on shelter and he was not feeling well, meaning he was sick, medically sick, he was not able to get to the clinic, which he typically goes via biking. In this same case, Brian went to the hospital because he got so sick that when I went to the street, I did the CVA test and he was positive for the kidney, meaning like he like
Okay.
could
Yeah.
have pyelonephritis. He went to the ED with the help of us. He was found to have an infection in the kidneys, infection in the blood, even infection in the prostate. And he stayed few days in the hospital where his methadone dose was increased. He left against medical advice. And when he went back to the methadone clinic, they gave him the old dose, a lower dose. So that was a mismatch. So I'm saying this because people that are in shelter is not only that they have more barriers getting to the clinics, but because of being homeless, they have less resources and structures to keep like a discharge summary, not getting wet, or having a cell phone. In his case, he lost his cell phone, to be able to get information and to have information readily available to show to the clinic. Those are two quick
Yeah.
examples. The other side, many times there are intersecting stigma, meaning people can be treated negatively due to having an addiction and being homeless. Those two, right? Stigmatized conditions. And how can that look like? In Brian's case, he started methadone in April after 5 years of him thinking, what should I do? What should I not do? And he's someone that uses a lot of opioids. I'm talking about 2 bundles
Mhm.
per day, which can be around 20 bags. And when he went to the methadone clinic, the first dose that he got in the intake was 20 milligram. And for us to have common language, typically clinics give up from 10 to 40 milligrams, complying with regulations. And he felt sad because he told the team members 20 milligrams would not hold me. Can you give me 30 or 40? But he was not given that. So he did not return that time in April. He did return later after we sent emails advocating for him to get possibly 40 milligrams because of his high, severe opioid
Yeah.
disorder.
That's very important. And I think that's one thing that I always encourage people to do. It's advocate for themselves. But in this case, it seemed like even
Yes,
though he advocated for himself, he wasn't heard
yes.
mainly because of that intersectionalized stigma that may
Mhm,
happen. The patients that I'm mostly seeing in my outpatient mental health clinic, most of them are housed, and
mhm.
even those that are unhoused, they're sheltered. They're already in a program on a list to get their own like supportive housing and all of that. So it's a different instances for them. So I want to take a look at, we've looked at that, but when we look beyond that, between people that are unhoused and housed, like what are some challenges may come up for those that are unhoused that clinicians should look up to or should look out for compared to those that are housed? Because here I am telling everyone, you should advocate for yourself, but someone did and he's seen differently.
Yes, of course. That's an important question. So, what do we know about being homeless and its relationship to mental health and substance use disorder? We know that, first of all, people with severe mental illness, chronic severe mental illness, without mentioning homelessness, those are people that are likely to receive less care and to engage less. And people that are homeless, they typically have issues getting vital documents, might not have an ID, their birth certificate, their insurance card, and they prioritize basic daily survival. I'm talking about getting money, that could be panhandling, getting food. If they have an addiction, getting the substance to not have withdrawal, over going to an appointment on times. We call that
Yeah.
competing needs. Competing needs are real. And we know that those that are unhoused, Dr. Owusu, like the data is that close to 76% of those that are unhoused have any mental health disorder. Around 66% of those that are experiencing homeless have had history of suicidal ideation, and close to 50% of them have had suicidal attempts. The majority of them, unfortunately, close to 50%, have been victim of violence. A big part of them, too, close to 40%, have been victims of childhood abuse. And many of them have substance use disorder, not all of them. And there are not enough studies. I think there's like big range of how much people have substance use disorder. What I can tell you is that the most common overall disorders for people that are unhoused, when they look at studies, looking at what are the most common disorders or diagnoses in people that are unhoused, the number one is alcohol use disorder. The number two is other drug use disorder, because in the data encompass many other disorders as drug use disorder. And thirdly, is schizophrenia. The two most common diagnoses in people that are experiencing hopelessness are alcohol use disorders and other drug use disorders. It can be cocaine, opioids, etc. Which one comes first? I think there's no like specific enough data to say what comes first, but we know that the majority of time, close to 65%, mental illness precedes homelessness. Again, we need to get more data, but we know
Yeah.
this. And homelessness affects people in many ways. It's a social determinant of health, being unhoused, right? It affects how you keep resources, what you can access. It affects how you get to the clinic. It affects how you maintain your medication. It affects how you can care for both your mental health and medical. I know people that live against medical advice with an abscess, and how they go about not only taking the antibiotic they were given, but being able to care for that wound, meaning like using just soap and water, because in many communities, they're not public bathrooms. So, how they go about getting basic needs as a safe space to just have water and soap.
Yeah. You've said so much, and it makes me so sad just to know the things that we're going through, the current state of affairs. It's really sad that people have to live life like that. And you've mentioned
Mhm,
multiple social determinants of health and how all of this sort of affect one another. One thing the literature shows is ACEs. All these childhood adversities, they really can affect someone. The childhood
mhm,
trauma, the environment they're growing up in, all of those things can affect if they're going to develop mental illness, the substance use that
mhm.
may come on later on in life or even earlier on in life. And I had the privilege to recently work on a study with a lot of data from SAMHSA that confirms most people that start using substances earlier, they are going to end up homeless compared to someone that didn't. And all of this comes back to that social determinants of health. So, given that we know homelessness is predicting lower retention, even after you may have made adjustments and offered services, are there other programmatic strategies that can offset some of this problems with retention and completion of treatment?
Yes, I will go to name some of that based on my knowledge. But something that I didn't mention, I want us to bring back, Dr. Owusu, is besides homelessness being a barrier to get healthcare and well-being, specifically with substance use disorder, we know that people that are unhoused are at higher risk of overdoses. And I just want to untangle that a little bit more, because they are close to 12 times
Oh my
more
God,
likely to die from an overdose compared to the general population. Again, 12
that's
times more
high.
likely. Many people, when they're homeless, they're on shelter, they want to hide, because if they're too visible, they can be asked to move, have their encampment being displaced. I understand that encampments can be difficult for the community. I understand also the other side, that shelters as the only option for homeless people is not the best strategy as well, because shelters can have difficult requirements. I see this context because many times homeless people, their encampments are hidden. They could live alone or in groups, but using alone in a hidden place put you at risk of getting help. So I just want to put it out there, because even in their survival strategy, they plan to be hidden in order to be able to stay in their encampment versus just staying outside without a tent or a sleeping bag. And that puts them at risk of dying from an overdose, because no one else can pay attention to where they are or how they look. So I just want to put that out there, because I think it's an important point, that unhoused people are close to 12 times more likely to die from an overdose. Going to your question of what strategies can be used to address substance use disorder in unhoused population. I think that brings the point of what is treatment with a health equity lens, right? And before we go to things that are very culturally responsive for unhoused folks, I think three main caveat that you should apply with everyone, not only unhoused people, is just first offering medications for addiction treatment, MAT. It could be alcohol use disorder, it could be opioid use disorder, it can be off-label treatment for cocaine use disorder, but giving medications for addiction treatment. The reason why I say this is because at times I have seen providers or healthcare settings preferring to start treatment if someone is in a shelter or in a program, not starting it right away. It could be because they don't trust them or they think they will, quote unquote, sell their buprenorphine, even if we know that we have data that when people even sell buprenorphine, the majority of people use it to treat withdrawal. Because buprenorphine is a quite safe medication. So first, just giving the basics, medications for addiction treatment because they work. The number one thing we can do for people to prevent overdoses is starting buprenorphine or methadone for opioid disorder. The same as the general population. Second, also similar to the general population, but importantly for unhoused people, addressing social needs because those will be competing factors in healthcare. And what that means, getting an ID, making sure they're connected to a case manager, helping them get a cell phone. And yes, maybe in your busy office, you don't have the time to ask all this and tackle this. But that's why it's so crucial to collaborate in care. So, to give you one answer to your question, what are best strategies on working with unhoused people that have substance use disorder? First, collaboration. You cannot do this work alone. As a provider, just identifying they don't have an ID and why that's important. If you have a housing voucher, you need an ID to use the housing voucher, right? If you identify those needs, you can refer to a caseworker or ask someone else or other organization in your community to help that person. You need to be conscious that because of those competing needs and the nature of addiction, many people that are unhoused with an addiction might miss appointments or they need more flexibility. There are clinics that have rigid requirements that if you miss, let's say, 3 appointments, you will be discharged. I think that there should be more policies for clinics that if someone is unhoused, try to have more alternatives on how to help them be more engaged. Could it be using telehealth? Could it be just being able to do a phone evaluation? How can that look like? Some clinics ask for people to do both medication management and therapy. And it could be person just could do the medication management. And we know that buprenorphine and methadone works well along with psychotherapeutic intervention and alone, right? So in a case like that, be more open to let that unhoused person come once per month, perhaps, instead of like every 2 weeks or once every 2 months, on top of the methadone and buprenorphine, for example. Specific to unhoused folks, it's very important to meet them where they at and be flexible. What that means. I myself, at times, have felt the uncomfortable feeling that I want to help someone to re-engage in MAT, but they don't want it at that time because they feel tired, they don't feel as hopeful for their treatment. And how do I hold that discomfort? As a psychiatrist, I need to know that can happen, that's expected, and I should just stay with them in care until they're ready to start treatment. And I think that's one of the beauties of street psychiatry compared to office based care, We have low threshold and more flexibility. We do understand that people have different priorities. So in our team, we don't discharge people if we haven't seen them in 1 month or 2 months. Of course, we ask our community collaborators to see if they have seen the person, but we keep looking for them. We have that flexibility. So, by us having that flexibility as a model of care, we are able to stay engaged with folks that could be missing because of X, Y, and Z. So, those people that we care, we try little by little to get them housed, meaning like in a non-congregate shelter. So there are congregate shelters and non-congregate shelters. Congregate shelters are like the most common idea of shelter that people have. It's typically women's in one side, men's in the other side. You need to arrive around 5 p.m. and leave around 5 a.m. You can have perhaps bunk beds, a lot of people in a specific area, non-congregate shelters. To give you an example, we have in New Haven a old hotel that was transformed into a non-congregate shelter where a person has a room. That room, they typically have up to one roommate and they can stay there the whole day. They can leave their belongings the whole day. So it allows more flexibility. So we as for psychiatry, we know those differences and we try to help our people using that knowledge. And we are ahead of the game. Like if someone has a dog, we know that they will need an emotional support animal letter before we apply to the non-congregate shelter because we know it's a requirement. So we do that in a way that things are not delayed as much because we have
Yeah.
that knowledge already, right? We know that criminal justice involvement is a barrier to being housed. And that perpetuates the substance use, perpetuates the mental health problems. And just to give you an example of how that looks like, Brian, the person that I told you earlier, he had many warrants in 2 cities in Connecticut. Because he has warrant, every time he gets a housing voucher, he's required to turn himself in
Oh,
before using the housing
oh, no.
voucher. The 3 times in the last 3 years that he has had a housing voucher, he has not used it because of the fear of going to prison or jail if he turned himself up. This year, we told him that we're gonna work together on those warrants, and how that looked like was I completed a form requesting that warrant to be vacated. And I provided a letter as a psychiatrist saying that Brian has been engaged in care with us since this day to this day. He had been engaged in treatment, and we just think that the warrants are a barrier for him to be housed, which in turn precipitates and perpetuates his mental health and substance use problems. Luckily, in his case, the warrants were vacated for Robusto. So that's a way a doctor can advocate and help people not directly into the opioid disorder, but we tackle something that we know perpetuates the opioid disorder and perpetuates homelessness to be able to get a step closer for him to be housed.
That's amazing how you're able to do that. I was actually recently talking to a guest that would be coming on who is an addiction psychiatrist, but also a forensic psychiatrist. And that was one of the things we
Oh,
wanted to talk about is that intersection between the criminal justice system and then just addiction
uh-huh.
in general. They coincide. And I always say, like, even just methadone feels so carceral. And sometimes, like, we have to talk more
Hmm.
about it, enlighten people on how to advocate for the people that they're caring for. And this is one amazing example. Another thing that stuck with me, because you are the second guest that's brought it up, is the uncomfortability of a lot of providers when it comes to giving buprenorphine or just any medication assisted treatment, and that they pause on it for, especially in certain populations that may be stigmatized. And it's mostly secondary to the idea of, well, they're going to misuse it, they're going to sell it. But then if you're
Mhm.
knowledgeable about how these medications work and the literature out there, then it reduces that fear. Dr. Bo had made a statement about, what if they sell it? If anything, they're going to be helping someone treat their withdrawals. And you said the same thing. So I think it's important to have spaces like these where people can learn that in those cases, like when you give buprenorphine, yes, there's that possibility that people may misuse it, but it's the same as any other
Mhm.
medication. I've seen people misuse their insulin. I've seen people misuse their Lexapro. It's like you can misuse any
Yes.
medication. So the stigma that comes with these controlled substance, I understand they may have more addictive potential, but there's education and there are ways that you can safely do it for a lot of the people. So
Yes.
it's amazing the work that you've been doing. I've learned so much. I'm like taking notes. I'm definitely going to go back and listen a lot, read more on some of the things that you've
Yes.
mentioned, like the statistic about people that are in house with substance users 12 times likely to overdose. That's really high. So when we see these people, we have to be more cautious as to how we even play a role and how we impact them. I worked in a
Yes.
CPAP,
Yeah.
and one thing that was tough was there's so many times where, as a PGY1, sometimes it's like, well, we don't have enough beds. Why are we holding people here? But then it was because if someone was homeless, they didn't have an ID, and it was past 10 p.m., they couldn't get into the shelter. So once you let them leave that emergency room,
Mm.
they're back on the streets, especially during the winter night. So what we would do is we let them
Yeah.
stay and sleep till morning. So they had somewhere to stay. They had the ability to have breakfast and then leave after that. And that little gesture comes back to the system that we have to hold people in emergency rooms just to keep them safe overnight and provide some of the resources that they may need. So hopefully we're able to get to the point where collaborative care is everywhere, and we're all like having a team of social workers, case managers. If physicians don't have the time to do it, we have a team that can help people get their IDs, make sure they're taking their medications. People that go home go to wherever encampment or shelters or spaces they may be in to check in on people as well. So we've learned a lot in the last segment of just you answer some of my questions. I wanted to take a little bit of a turn and talk about a case and see how we can approach someone. I have Mr. B. We could take this as Mr. Brian. Well, Miss B. Sorry. And then she's a 34-year-old woman. She has a 7-year history of opioid use disorder. She has cycled through shelters and couch surfing for the past year. By treatment enrollment, she reported homelessness and she was uninsured. She begins buprenorphine in an outpatient program. Over time, she misses appointments. She has trouble safely storing her doses, and sometimes she sleeps outdoors and must rely on unpredictable transportation. She also struggles with untreated anxiety, prior to incarcerations, and limited social support. She consents to restart care, but she fears she will drop out again. So, our first question is, given Ms. B's instability, what is your prioritized treatment plan that you would make for her?
The first thing that came to mind, and it's a motto that we truly keep in street psychiatry, is just building that trust for Miss B to continue returning to us. Because in reality, if they trust you, they will want to see you again. And if you're able to accomplish that, you get one of the most important things. They will want to see you again. Specifically in people that have been unhoused, she has been in the criminal justice system. There are many stigmatizing identities that she has that put her at risk of discrimination and truly mistreatment for different healthcare system and non-healthcare system. Second, being able to offer more creative solutions that are also first line treatment. In her case, she's in buprenorphine and she missed doses. Talking about two tools that can be used, which are Brixadi and Sublocade, which are the two forms of long acting buprenorphine that are available at present. Both have buprenorphine. It's just two different forms of the long-acting injectable. And sometimes people, I can tell you that my experience with unhoused folks, one of the most important things that come up is, oh, but I don't want to lose my films. I'm scared that I will be in withdrawal and I will not have enough film. And I typically tell them that if I started them in Sublocade, for example, I typically give 1 week of Suboxone. Just because I know that in that first week, people can have still cravings and even withdrawal while the Sublocade is getting into the system. And to be honest, FDA changed how we can prescribe Sublocade this year. Like now, you can give Sublocade after showing that you tolerated one dose of 4 milligrams of buprenorphine, and you can give the Sublocade that same
Nice.
day, just to give you that piece of information. Second, with Sublocade, FDA approved as well because they know people take time to have the buprenorphine getting into the system. Also, it's approved that after giving the first injection, you can give the second injection as fast as on day number 8. And once you start giving the monthly injection, you can give it up to every 26 days. So three updates from this year for Sublocade, just for people to know. And in my experience, because this has happened, I had a female this past month. She was discharged from the hospital after an overdose. She was fortunately restarted in buprenorphine, specifically Suboxone. And before she left the hospital, she was given the first dose of Sublocade. We were able to continue the Sublocade, and unfortunately, she was missing. We didn't see her for about 1 week and a half. When we got contact with her, something that she told us is, I didn't crave. She was almost like 5 days late for her next injection, but she told us that she felt overall good, that the Sublocade had some coverage after the 28 days. So that was a learning point for us and for her, because trust me, they spread the word with their peers. Like, oh, I'm taking Sublocade, da, da, da. Even to be honest, Dr. Augusto, I have people that I have offered Brixadi, and they tell me, no, 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 I want Sublocade because so and so is on Sublocade, and they say it works for them without them trying Brixadi. But I'm just sharing it as once it works, they can share their knowledge with others. And the long acting, not only once you have it for a couple of months, not only cover for those 28 days. In my clinical experience, I have seen that provide some coverage in people some days after they are due for their next injection, which has been positive because we can restart the buprenorphine or the other Sublocade injection quicker. And they're covered or they're more protected for overdoses. So in summary, building that trust, because if they want to return to see you, I think that's a win and a move in the right direction. Offering long acting buprenorphine because it is an option. And thirdly, connecting to a caseworker because it takes time, but it's like one of the first steps to start helping them be shelter or house.
Yeah.
And they're like in New Haven, we have case workers that are peer specialists too. So they have a deeper understanding of what it is to have a substance use disorder because they had that lived
Yeah.
experience.
I think the lived experience part of it is very important. When we go into the emergency room, sometimes as the clinicians, we say all that we can, but someone is still not, they're like in this contemplative stage. And then we're like, okay, we have a friend that will stop by later to check in and then we'll come back later. And that friend is a peer specialist. And most of the time, after we go after them, the person is more eager to engage in treatment that we had offered earlier because they had a conversation with someone that was more likely to have had the same experiences as them.
You're
Yeah.
absolutely right, Uso. It makes a difference. They have a credibility different from our credibility as doctors.
Yes, definitely. And one of the things that you had mentioned with the example that you gave was your lady didn't like they went missing. And similarly for Ms. B, she can go missing. So what are some of the things that we can do in cases like this? What could have been done to reduce like dropout? She came back and she was found, but it looks like there was something that kept her from initially coming back, right? So what are some of the things that we could do to reduce that? If you were to give someone like 3 tips on what they can do, what would it be?
I think something as simple as having a piece of paper where you write the phone number of your team and give it to them. Something as simple as that is important. Second, again, them trusting you, because in this case that I told you about the patient that I was working with, it was not that she dropped out from our care. It was that unfortunately she had a fight in the non-congregate shelter and she was kicked out
Oh,
of the shelter
yeah.
because of that. And as a result, she didn't have a place to stay, and she ended up going to a place where she was taken advantage
Oh,
of. And we were very
yeah.
concerned. We just lost a point of contact with her, and she couldn't contact
Yeah.
us.
So it sounds like, just in general, keeping in mind that dropout rates can be influenced by multiple factors. It could be provider based, it could be patient based, it could be circumstances and situations based. It could be so many different
Yes,
factors that influence that. So thinking broad and making sure those
yes,
strategies may cover all of these things, but also asking the person the whys, or what could be trying to get ahead of that and address it.
correct, exactly. And I just want to say quickly to a prior question that you asked me, what can we do, best strategies to treat Miss B? You mentioned that she had anxiety. It's important to put a last name to the anxiety. And what do I mean by a last name, Dr. Owusu? And I tell all my trainees, we need to be specific. What kind of anxiety is it? Is it general anxiety disorder? Is it panic disorder? Is it social anxiety disorder? Could it be post traumatic stress disorder? Could it be something different like OCD? But we need to pinpoint what the person had to help them better. I don't like it when we leave it vague because it leads to a lot of
Yeah.
assumption. And we don't do that with medical problem. If someone has abdominal pain, we just don't leave it 55-year-old person with abdominal pain that was admitted because of fever, blah, blah, blah. No, that abdominal pain can be from a specific organ, could be the gallbladder, could be the kidney, could be the pancreas, could be because inflammation, could be because trauma. There are many reasons for abdominal pain, but we typically narrow it down so we can have a narrow treatment option. The same with anxiety disorder, the same with depressive disorder, the same with psychotic spectrum disorder. I like to narrow it down because we help them also to understand better and ourselves. And it helps us to manage the substance use. Like it happens often. Something that was humbling yet sad, but nice because it's nice when people go very vulnerable with you. A female that uses cocaine. She has cocaine use disorder. And she told me that she uses cocaine to stop hearing the voices of the ex-husband. Important for me to hear that and digging more because he spoke about her PTSD and how her PTSD fits the cocaine use disorder. So me being able to know that the PTSD was causing a lot of anxiety and she had psychotic symptoms related to the PTSD that perpetuated her cocaine use. That was helpful information for me to provide treatment. So it's crucial that we target this substance use disorder, the social factors, collaborate with the community, treat the anxiety disorder and knowing what kind of anxiety disorder it is. Again, I'm hammering a lot. Continue to build that trust. And trust me, building trust doesn't mean that you don't put boundaries to confrontation, right? I have had disagreement with my patients. For example, they ask me for a benzodiazepine and I don't think that's warranted at that specific time. And I tell them, listen, I cannot give you this because of this and this and this. I can give you this, this, or this. Or when I'm working on a benzodiazepine taper in an unhoused person that have had episodes of being extra sedated, I tell them, I know I'm not doing what you're asking me to do, but I need to taper down because of this and this and this. But I want to be a plan with you for this benzodiazepine taper. It's not easy, but that's also part of building trust because you're being real and honest with them. I'm telling you what I'm thinking and what I would do, and I want to work this with you. I know you might not like this plan, but we need to work on this because the plan that we have now is not safe for you. That's also part of
Yeah.
building
I
trust.
think rapport building is very important. And I always tell my patients this is a collaborative care. You are in the driver's seat, and I'm here to guide you through it. But there are going to be some times that we don't agree on things. But please do tell me if you disagree with me or something. So it's like a two-way communication. You have to communicate just as much as I communicate with you. And I think that's very important for people to be able to feel comfortable to do that with their patients and build that trust
Yes.
and rapport with them. I wanted to look at Ms. B's case and some of the other examples that you've given, and look at the idea of policies and system level changes that we can advocate for that would reduce one, just the structural barriers that people face. For instance, when we spoke about the example of the incarceral system and how I have to turn myself in to use my voucher that I'm not gonna go, and it's gonna impede or become a barrier to me actually getting my medication. If I don't have my ID, I can't go into the shelter. But if it's after 10
Mhm.
p.m. or there's only certain days that they do drop-ins at the shelter, like there's so many different regulations when it comes to how things are managed. And I I try to understand for the best part. I know these rules, policies are in place to help, but there's those barriers. So what can we do policy wise, system level wise to help bring change?
The first thing that came to my mind, and we have not spoken enough about this, very specific to the unsheltered population, is how do we address encampment? Places where people stay in the street. And it can be with a tent or it can just be like a blanket and there's two people down the blanket. But the reason why I bring it is because studies have shown that people with continuous encampment displacement have increased overdose mortality, higher rates of hospitalization, lower initiation in medication for opioid use disorder. I will repeat, lower initiation for medications for opioid use disorder. And that's problematic. So I say this because, just to be clear, for unhoused people, being in an encampment is not their ideal situation. For unhoused people, being in an encampment is not an ideal situation, but it is a better alternative than the shelter. Because in the shelter, they might not be able to leave at 10 p.m. to have a cigarette or to use substances to avoid withdrawal or be with their partner or have their full autonomy or stay with the belongings, just to give examples. So I say that because when we are looking at unhoused people that are on shelter in the street and they will be removed from their area, I truly think offering shelter as the only option cannot be the way to go because we have been doing that for decades and still many people decline to go to a shelter. So there needs to be more options. And that can look like investing in more non congregate shelters. Like I explained, people can stay there 24 hours, they have more privacy, they can leave their belongings. Second, there are other examples of alternatives, like I believe in Rhode Island as well, they're using tiny homes as another step before being housed. There are models of non-sanctioned encampments, like literally the city allowing a specific place to be used for people to stay. This happened in New Haven during COVID, not officially, but there was a permission from the city and police for a specific area called El Abrazo Boulevard, for a specific area to be used for unhoused folks. And you will see many tents in that area. Unfortunately, that was removed about a year and a half ago, but that was a place that was allowed to have people for the since COVID. And I think, again, it was not their ideal situation. There was not the ideal place to live, but it was better than the alternative of the shelter to be while they were trying to get addiction care, get their IDs, and get housing. Having less strict requirements in addiction clinics, meaning like providing mandatory urine drug screen in every appointment, for example, or not allowing someone to stay in care if they're not doing therapy. And the reason why I bring this is because evidence shows that buprenorphine alone and methadone alone do provide benefits, right? I think we don't need to reinvent the wheel. Like, for example, with methadone, there are more data on how to go about initiating methadone or how to manage missing doses of methadone. Like if someone misses 3 days, how do you approach the person if they're using fentanyl on the streets? Now we have more information on how to approach that. And people can learn that by going to the ASAM website, right? Or using information from PCSS, another helpful tool in addiction care. So it's like how we can provide the knowledge that we have now to others, and how can we treat unhoused people more humane. And it's difficult because we are now in a moment where there has been a lot of policy change for unhoused people. And I think because that happened, that has an effect in other states. So we need to be creative on how we advocate for this, being able to continue the message that when we think about safer use, it's not enabling the use, but just understanding that there's some people that might not be ready right now to do the big change, but they're willing to do other things to be safer while they use. So I'm saying this in reality because I know there are things we can do, but we also need to acknowledge what's happening as well. So that will inform what we're doing now in terms of advocacy and policy change.
Definitely. I think when it comes to harm reduction, just in general, you have to be so careful in, like,
Yes.
you want to advocate for people, but you also don't want to get everything taken away from them, especially in this instance. So that's why a lot of us
Yes.
are more careful as to how we're saying things and how we're doing this to still make sure we're able to give the care and the resources to the people that need it. So I am happy and glad that you said that and recapping all of the things that we've said. Thank you so much for the education that you've provided, for the tips, the pearls. There's so much that I have learned myself. I tend to think I know more about addiction than the average trainee because of all the stuff that I've done, but I still continue to learn, and I'm always in awe of senior colleagues and attendants like yourself that are more than happy to teach and spread the knowledge and the experience that they've had. Thank you so much. Our last segment is actually a Pearl tip section where you have the opportunity to, of everything that we've talked about, you can give us a summary of it, and then you could teach us a Pearl or a mini crash course of the topic that we just talked about. and also talk about if you have any things or anyone you like to shout out or any work that you want to highlight. This segment is your
Mhm.
opportunity to take us away.
Perfect. Well, I will pass a pearl of wisdom that I got in my residency by a mentor, Dr. John Renner. And he told me numerous times, Dr. Owusu, I'm talking about numerous times, the following: Fabiola, just be patient. And he just repeated again, just be patient. And why he was saying that? Because, of course, I wanted to help the patients that I was working with, but many of them were not ready to start a medication, or they were still not doing the task or the homework that I provided. And he always said, just be patient. The fact that they're still coming to see you is favorable. It means that they're willing to work with you. Otherwise, they will not be coming to see you. And I think that's applicable with the unhoused population, because many times, in my experience with street psychiatry, that we're more flexible. Changes do not happen in 1 month or 3 months. They start trusting you, and when they trust you, they start listening to you. And when they trust you and they listen to you, they could decide to take action on what you recommended. So, first pearl, just be patient. Second, there's truly a heterogeneous experience of homelessness. And if someone tells you that they're unhoused, yes, you can ask, where are you staying now or yesterday? Ask them, how has that been for you? Is this the first time you have been unhoused? Tell me what resources in this community help you and what don't help you as much, so you can learn as well from them. When we think about medications for addiction treatment, I want you to think about quality. And what does it mean, quality of MAT? For me, it means a good dose, meaning not underdosing. Second, them staying long term in treatment. And I typically ask people, the minimum I want you to be methadone or buprenorphine is 1 year. And there's data to back that up, because I know, for example, with methadone, people that are 3 months or less, long term benefits are not there. You have long term benefit when people have been at least 12 months in treatment, quality treatment. And lastly, the last tip I will say is, as a provider, you also have power. And I was surprised that this year, when I wrote just a letter, which I attached to a form requesting for the warrants of my patient, Brian, to be vacated, I was surprised that after I submitted that, the warrants were vacated. So we have a role in addressing social determinants of health in different ways. It's not that we're going to solve the issue of homelessness for everyone, to be honest, but I was able to do something that is getting him a step closer on top of the
Yeah.
medication.
That is so, so amazing. So, for those that missed everything that Dr. Arbello just said, one, you have to be patient, and it's important because we work with a population that you're going to need patience. And even generally, as a human being, if you're not patient, I don't know what you're doing. Two, just having compassion and showing empathy. So when people are telling you about their housing situation, ask them how they're doing, not just where do you stay. How are you actually doing? What has worked for you? What resources are you using? And you might just learn something more, because the people that are living it, trust me, they know a lot more than some of us do. And thirdly, is also making sure you're given quality treatment. And this is so important, not just given the medication and out of fear or uncomfortability of misuse, you're underdosing people. So make sure that you are giving them a quality dose. If you need to bridge them, you're bridging them. All of this is amazing. But most importantly, remember to use your power as a provider. You have no idea how much or what you can do with just the power that you have as a provider. So please use that. And with that, we are so grateful for you, Dr. Arbelo. I cannot even say how much grateful I am. You were here so early at 8 a.m. and thank you so
Of
much. Thank
course,
you.
it was
Thank you.
great.
I really do appreciate you taking the time to come and be a part of this. This is my little way of advocating. So when I meet people
I
that
love
share
it.
similar passions of teaching and advocating, it makes me happy and it brings joy and it gives me hope of what we're doing. Is there anyone or any projects you like to highlight or shout out?
Well, I want to shout out one of my colleagues who founded the street psychiatry team here in New Haven, Connecticut, Dr. Emma Law. I feel lucky to call her my colleague and friend. And this was her residency
Oh
project
my
in a
God.
way. She trained at Yale. And she actually started this program in 2019 because there is the street medicine field, but within street medicine, there's also street psychiatry, more focused in psychiatry. And there are many street psychiatry teams now. Like it's growing as a field. We actually had the first street psychiatry
Yes, we did.
conference in
Yes.
New York, in Harlem, at Johnny Medical Center. But I want to do a shout out to her for making the path and allowing me to continue to learn and just making another model of care possible. We're all learning. We're trying our best.
So that's so amazing. Shout out to all the brilliant psychiatrists out there. And to have your residency project become something that 6 years later is still ongoing and is still helping people is just amazing. And it shows to the power that we have, even as trainees, of what we
Mm-hmm.
can do. So that's amazing. Thank you so much. I really appreciate you being here. Thank you.